So we'll start by the first controversy, which is the name of the tumor. The Phyllodes tumor is rare in many aspects, and diagnosis and management also remain controversial. It originates from the Latin term phyllodeum and from the ancient Greek phyllodes, which resembling a leaf is the meaning. Now, the older term was histosarcoma phylloides, which is still used by some people, but this has changed according to international meeting in the WHO to Phyllodes tumor as of 92. So right now we should use this term. Now, because of its varied origin, it's pronounced in various ways. And that is probably the most controversial. So if you look at the name, you can call it Phyllodes, Phylloides, Phylloides, Phyllodes, or any combination of a short or long version of the vowel sound. So it doesn't really matter. I just wanted to say that Phyllodes is what is more commonly used. When I went on the internet and checked, there were actually 7 different ways people were pronouncing this all over the world. So just to start with an interesting point, I am going to use Phyllodes. You, because of its origin, you can use whatever you want as long as your audience is understanding what you're saying. So where does this term come from? As we know, it's leaf-like. And here was another interesting point. The leaf-like appearance is both in the gross cut section as well as in the microscopic appearance. As you can see here on the left, there is a large Phyllodes tumor which has been sectioned, and the edges do appear leaf-like. And on the microscopy, which is more typical, you can see the very nice leaf-like pattern of the growth of the edges of the tumor within the cystic space. So that's what gives it its name. Now, I've chosen 2 review articles which have actually given a lot of information about these topics. And you can look at these yourself in more detail if you take down the references. One actually was looking at current clinical practice across a whole international cross-section of surgeons, so that brings in the international perspective. And the second one was a consensus review from the pathologists below, because there was a lot of difference even among them. And one thing we learn as surgeons is, although we grow up believing that pathology is the gold standard, we have to understand that there are a lot of limitations to even their assessment. And finally, it is a clinician, you, who has to take the decision, and pathology is only one pillar in the support of your decision. And don't put all the onus of responsibility on the pathology. So here comes the first controversy, which is it's difficult to differentiate cellular fibroadenoma versus benign Phyllodes tumor. Now, the common problem we face is that you get a lobulated, say 3 or 4 centimeter lesion, maybe in a 24-year-old, and then you core it. And what does it come back as? It is reported as benign fibroepithelial lesion, not otherwise specified. And they also often write that benign Phyllodes tumor is a possibility. So it basically covers both cellular fibroadenoma and benign Phyllodes tumor. And this is where pathologists have a problem in differentiating these 2 regions. So in one study, there was 21 lesions were given to 10 specialists, and only in 2 out of the 21, they found concordance in the reporting. Whereas if you take the differentiation between a cellular fibroadenoma or a benign PT on one side versus a borderline or malignant Phyllodes tumor on the other side, the concordance was much better at 53%, but still even differentiating benign versus malignant, there was not full concordance. So you can see the scale of the problem. So we need a lot of information when managing these patients, the clinical aspect, the imaging, our own palpatory findings, and finally the pathology on the core biopsy. And it is very imperative that these lobulated lesions that are larger than, say, 2 or 3 centimeters, that we core them, because that gives a much better chance of getting an accurate pathology report. Now, another point was, is this Phyllodes development from a fibroadenoma? It has been thought that perhaps a fibroadenoma, which is also what we call a biphasic tumor, if you've heard of that term, referring to the epithelial component and the stromal component of fibroadenoma and a Phyllodes, both of them show a biphasic nature to their pathological appearance, histopathology. So it was thought that a fibroadenoma's mesenchymal component could actually transform into a Phyllodes tumor. And many studies were done to try and look at this, whether it's possible to prove that. You can see that maybe at the end of the slide, the second last one here, 11 of 36 cases of malignant were associated with the prior diagnosis of fibroadenomas. So some studies have shown that fibroadenoma association with Phyllodes is more than what we would expect. And we find that possibly, as this study here, the fourth study, shows areas of stromal expansion in 3 of 25 fibroadenomas were monoclonal. In addition, 9 of 12 showed monoclonality in Phyllodes tumor. So what we are thinking is initial polyclonal expansion of the stromal component of a fibroadenoma then may become monoclonal, which confers its neoplastic nature and then develops into a Phyllodes tumor. Now, this is of interest, but really not of practical management yet, because we can't manage fibroadenomas because of their possible Phyllodes potential, because fibroadenomas are far too common and Phyllodes are a rare tumor. So it's interesting to know, but not really of practical use. Now, what is the relationship? They looked at genetic components also, and what has been found that this MED12 mediator complex 12 gene in codon 4 mutation seen in both fibroadenomas and Phyllodes tumors. And even with this, the linear progression still remains controversial. So now, the last step in the genetic evaluation, the most recent study, was looking at a 16 gene panel sequence to test an international cohort of 300 odd fibroadenomas and 400 odd Phyllodes tumors, and found that the molecular alterations more frequently detected in Phyllodes tumors were these MED12 third promoter, etc., compared to Phyllodes tumors. And a highest frequency was the third promoter mutations in all the Phyllodes tumor subtypes. So this again underscores a possible correlation, and maybe this may develop into a management tool in the future. So the bottom line is it really necessary to differentiate between a cellular fibroadenoma and a benign Phyllodes tumor when you as a clinician are sitting, you got a 20 to 25-year-old with a 3 to 5 centimeter lump that's lobulated and mobile? Do we really need to alter our management based on our suspicion? So we would think that, okay, if it's a fibroadenoma, then just an excision is enough. I don't have to bother about the margins. Whereas if it is a benign Phyllodes, then I need to have a wider margin and make sure that I reduce the chance for recurrence. So practically, it is seen that the excision rates post-lumpectomy don't really change very much whether excision is done or a wide excision is done in the benign Phyllodes. suspicious setting. I've even had cases, it's so complex sometimes that the core suggested phyllodes, but when I excised it, it said it looks like fibroadenoma. And then the patient comes back with a recurrence, and then they say, yes, it's phyllodes. So it's, a mixed bag. And I think you have to take the call based on your clinical evaluation, based on the patient's desires as to whether to avoid recurrence, as well as how your operation is going to affect osmosis. So these will be the points whether you decide to go wide or not. But when it's a benign fibroepithelial lesion, then the stakes are not so high for your decision. So I would say choose according to your patient. You individualize the decision whether to go for a wide margin or not. Now here's, if you look at the patient who came with a large tumor, it's only a 17-year-old, and you can see it's a very large tumor. Clinically was 12 centimeters, and the skin was stretched, it's lobulated, there were some veins. Now, when you have a 17-year-old with something like this, what you need to consider is this more likely to be juvenile fibroadenoma in this age group. And one thing I've found is the pliability of a juvenile fibroadenoma is more. You can actually mold it when you palpate. That is a much more hyperplastic component in it than a regular benign Phyllodes tumor. So this one, we went and did a inframammary incision and just excised it without a margin, and she's been doing fine. The final report was juvenile fibroadenoma. But when this patient appears to you clinically, you will suspect that it could be Phyllodes. Now, Phyllodes is not common in the young age group. Unfortunately, if you have 13 to 17 age group with such a tumor, or even up to 19, I would say, much more likely to be a juvenile fibroadenoma than a Phyllodes. In this young age group, the cosmesis will be a problem, so it would be better to take a more conservative approach on the excision. But the same thing in an older, say 30, 35, then the likelihood obviously of a Phyllodes is much higher, and you have to manage it as with a proper margin. Now the margin will come to a little later. One more issue is differentiation of a rare sarcoma from metaplastic carcinoma. The Phyllodes tumor component is in a malignant Phyllodes is like a sarcoma. That's why the term cystosarcoma phylloides was originally used. A malignant Phyllodes forms max about 20% of tumors, and it may be reported either as a malignant Phyllodes directly, or it can have heterologous differentiation. It may take on characteristics like a liposarcoma or any other type of sarcoma. So according to its characteristic, if it has a differentiation, then you call it by its metaplastic nature. Now, metaplastic carcinomas, which have arisen from the epithelial component, can also have sarcomatous appearance in some areas, but this can be differentiated clearly by cytokeratins and P63. So here we can clearly make a differentiation. Is this a metaplastic carcinoma looking like a sarcoma, or is it a malignant Phyllodes with the sarcomatous component? This requires IHC markers to make the differentiation. Now, when we look at the subtype classification of Phyllodes, the pathology agreement is to divide it into three categories according to this 2012 WHO consensus conference. You have the benign, borderline, and malignant types. So this is based on 5 characteristics: stromal cellularity, stromal atypia, mitosis, stromal overgrowth, and tumor margin. Here, the main difference on appearance, as you can see in the picture below, is stromal cellularity and cellular atypia. So here's benign, this is moderate, and malignant. Now, in these three, you can see the difference in the cellularity. This is on lower power view, and the atypia can be made out on the higher power view, which will be mild, moderate, and marked. Now, the problem here, as you can see, is that it is not quantified, but is the pathologist impression between what is mild, moderate, and marked. So this is where the comparator between pathologists gets complicated, because it's a call based on appearance. So the only quantifiable component is the mitosis, which is per 10 high power fields, less than 5, 5 to 9, and more than 10. So definitely we require the more than 10 mitosis high power field component to be sure that we are dealing with a malignant Phyllodes tumor. The other components are stromal overgrowth, again subjective, and the tumor margin, whether it is focal infiltration or gross infiltration, again subjective. So you can see a lot of this differentiation is subjective. So we have to. Now, importantly, what as clinicians we have to realize is the borderline category was evolved because of this subjective nature. But the behavior of tumors is basically clinical behavior is benign or malignant. And in most clinical studies, we have seen that the borderline category behaves like a benign tumor. So we don't usually see metastatic disease, which is what we are concerned with in the borderline group, if it is properly assigned. And metastatic disease or threat to life is only in this malignant category. Now, what about the role of hormone receptors in these tumors? It was surmised that maybe there would be estrogen receptor expression, and no significant association, however, was found that when estrogen and androgens receptors were expressed in the tumor. So that has not been of practical use. It is surmised that epithelial stromal interactions may have a role in pathogenesis. So that has been something that has been looked at. It is thought that the epithelium, although it looks like an innocent bystander, actually produces mediators that may set off the monoclonal expansion of the stromal component, because it has been noted by pathology studies that the monoclonal expansion usually occurs adjacent to the epithelial component. So there is an interaction there, and that is a big area of study now, how that happens. WNT pathway mutations have also been described in these lesions. Now, in imaging, strategy is not a major issue here. Generally, mammogram and ultrasound is the standard that we use. Perhaps MRI will be able to give some more features and also pick up a rare associated breast cancer, which is being hidden in the regular imaging categories. Here you can see an ultrasound showing the lobulated, very hypoechoic area with some cystic spaces. In the mammogram, it is just a large, dense lesion. In the MRI here, we can make out some more characteristics, and especially the relationship with the muscle and chest wall components, because this is useful. As you know, the MRI is done in the prone position. So the contact with muscle will be shown better in the MRI. Now the big question about surgical margins. How much of margin do we need to take? If we look at the benign phyllodes, as I mentioned earlier, in relation to the fibroadenoma, The benign phyllodes can be excised without margins and followed up, especially in younger individuals where the diagnosis is doubtful on core biopsy, and the recurrence is usually benign. So there, it has not been shown that a very wide margin really is required. In these categories, ideal margin needs to be determined keeping the tumor and cosmesis factor, as I mentioned earlier. But now when we come to borderline and malignant or recurrent tumors, then definitely the margin becomes a much more important criterion, and we require a tumor-free margin. The next question is how wide should this margin be, and that has been the subject of a lot of debate and study. 10 millimeters or more is recommended by some, though we don't have robust evidence to support it. So, and a prospective randomized trial, as you know, will be very difficult to generate in this rare kind of tumor. Now, one interesting fact of the large phyllodes tumors, as you can see here depicted, is in the older patient with a ptotic breast. If they have a very large retroareolar mass like this, it actually stretches the skin because of the weight and has an expander effect, which you can see the skin getting stretched and actually allows primary closure much more than one would expect for such a large tumor. This is just a small clinical point, but it's very important that you get an adequate margin beyond the edge of the tumor. And the basic dictum in operative planning is you don't raise any flaps. So you must go beyond and cut straight down onto the chest wall so that there's no chance of getting close to the margin of the tumor. There have been some theories as to why this recurrence is so common, whether there is extension pseudopod-like into the surrounding tissue, similar to pleomorphic adenomas in the salivary glands. And this has been noted in the pathology when we deal with malignant phyllodes tumors. The tumor actually extends into the surrounding tissue irregularly like pseudopoda. So there, definitely a wider margin makes sense. But in the case of benign and borderline, there is no such extension noted on pathology. And what I would say is you take out the tumor in such a way that you should not contact the margin at any point. And that becomes very important, especially when you're going to the posterior aspect. Sometimes when you pull, you tend to go inadvertently in towards the tumor. So you must stay away from the tumor, make sure that your margin posteriorly is adequate. And that's where I think we do get into problems. So this is an example of your slide will come a little later. Yeah, multifocal recurrent phyllodes case where this patient was operated 3 times, and you can see it's very rare. The tumor has recurred multifocal areas. So obviously the tumor had been breached in different points of its capsule, and the recurrence has occurred practically all around the tumor. So this is the kind of thing that you want to avoid. So that required a very complex procedure, a very wide excision and mobilization of abdominal flap as well as the LD component to cover the defect, and then a split graft was used for skin cover. This is a paper that was published from the Tata Institute. That's Professor Anurag, Kamal Kataria, and Professor Badwe, who had recommended a 2 centimeter 3-dimensional excision with overlying skin and underlying muscle. And again, the important point, avoid raising flaps. So when you have recurrent tumors or proven malignant tumors, then it would make sense to do a wide excision as much as possible to prevent a re-recurrence. This is from our own experience, we published from Vellore retrospective analysis of 150. Dr. Pooja with us looked at this data. The clinical challenges in management. You can see that the benign was 77 out of 150, borderline was 24, and malignance was 49. Of course, being a referral center, we got a little higher percentage than usual. So here you have recurrence. We found 20% in the benign, 41 in borderline, and 53. So as the tumor becomes higher grade, we found more recurrences. And the lump size also, you can see, was more in borderline and malignant, but not of great difference because the range benign went up to 30 centimeters, same as the other two. So they can get quite big. The size per se may not be a major differentiator. The core biopsy and the clinical behavior pattern of growth is the important feature in clinical diagnosis. So small Phyllodes tumors tend to get confused with fibroadenomas and higher recurrent rate post lumpectomy, possibly. The technique of excision, if you have a suspicion that it may be Phyllodes, is important that you handle the tumor carefully and have some tissue between you and the capsule. You don't have to aim for a large margin, but just make sure that you have some tissue so that you don't harm the capsule. And I think that is where in India we get patients with a lot of recurrence post-lumpectomy. How you would handle a very classic fibroadenoma would be different from how you would handle a larger lesion, which is still doubtful whether this could be a benign Phyllodes tumor. Now, the larger tumors, more than 10 centimeters, do have a higher malignancy rate and higher recurrence rate. So we have to treat larger tumors also with a wider margin. Now, if we look at the NCCN guidelines, we have Phyllodes tumor in one of the categories, which comes under the findings to differentiate between fibroadenoma, Phyllodes, borderline malignant, or malignant. So when we have a benign Phyllodes, it's only clinical follow-up. When we have a borderline or malignant, then wide excision without axillary staging is important. If we have a core needle biopsy diagnosis preoperatively of intermediate or benign, then again, as was mentioned earlier, they have recommended only excisional and not stated a margin is required. Whereas borderline or malignant definitely requires a wide excision. The second issue is also in a recurrent tumor, if there's no metastatic disease, then a re-excision with wide margins without axillary staging is recommended, and to consider post-operative radiation. If there's metastatic disease, then you use the same principles as soft tissue sarcoma of metastatic disease, so it will be chemotherapy. So there's no prospective randomized data supporting the role of radiation. Now this is another controversial point, and we don't have very definite data to decide who needs radiation. But however, it needs to be considered when you have recurrence with locations close to chest wall to avoid the morbidity of a chest wall recurrence definitely. So some teams have published findings from radiation centers where they would recommend radiation in all malignant tumors, in all recurrent malignant or borderline tumors. The role of radiation for recurrent benign Phyllodes is still not established. So here's a slide takes us through this. So if you have a core needle biopsy with fibroid, final diagnosis fibroadenoma, it's only follow-up, it's benign, borderline or malignant on core needle, then you do the wide excision without axillary staging. If benign, observe. If malignant consolidation, if greater than 5 centimeters with stroma load overgrowth, then you can consider the sarcoma protocol. This information came from the MD Anderson Center. This is the only one that's available now for this category from an independent center. So the role of radiation, as you can see here, is more aggressive than what is recommended in the NCCN. So I would suggest, if you're in this situation, you need to have an MDT and discuss an individualized decision with your radiation colleagues. So this is from our own center, where in Vellore we looked at the types of tumors that were offered radiation. So you can see in the benign category, nobody had adjuvant radiation. In the borderline, 7 out of 21 were offered radiation. And in the malignant, 9 out of 16 were offered radiation. So it was concluded that surgical resection with adequate margins gave excellent local control for benign and borderline tumors. For patients with borderline and malignant tumors, local radiation is useful if margins are close or positive, even after the best possible surgical resection. There is a trend towards improved local control with adjuvant radiotherapy for malignant Phyllodes tumor. As you can see, because the numbers are not enough, we could not show significant difference, but there appear to be better local control in radiation for malignant tumors. Now, the metastatic malignant Phyllodes seen in all studies has very poor outcome. So that is what we are trying to prevent. Metastatic disease, most of it occurs within 6 months to a year following primary presentation, and more don't survive more than 2 years. A very aggressive disease. What about systemic therapy for metastatic disease of unresectable malignant? It should be treated like other soft tissue sarcoma protocols. You have options of ifosfamide, adriamycin, cisplatin, etoposide in combinations. There is no targeted therapy yet. So and also the role of adjuvant systemic in the situation of non-metastatic but malignant aggressive appearing tumors. Can we give adjuvant? It is not clear yet. There have been, like in the MD Anderson protocol, option of using a soft tissue sarcoma protocol. But I think most centers don't do that. We don't offer that. This is our experience from Vellore with metastatic malignant Phyllodes. It's a very aggressive disease, and an analysis of 7 cases show that here you can see out of the 7, 6 were already died, usually 2 months, 6 years, 1 year, 1 month, 8 months, and 1 year after surgery. The only one who was documented as alive at the time of the study unfortunately presented again with disease and passed away. So we have no survivors with metastatic disease as has been reported worldwide. The follow-up guidelines in NCCN document is recommended as up to 3 years. We have mammogram and ultrasound can be used routinely, but more importantly, it's symptom-directed screening. So metastasis like sarcomas occurs mainly to lung, bone, and brain. We have one rare case who presented 12 years after the initial resection of malignant Phyllodes tumor, presented with a bone metastasis in the femur, isolated, was resected by the orthopedic surgeons before it was discovered it was actually metastatic 12 years after the primary. So these rare possibilities are also there. also finally expired of the disease after using systemic therapy. So the consensus article that I mentioned in the beginning actually suggested perhaps a 5-year follow-up would be better when you're dealing with Phyllodes tumors. So with that, I come to the end of this presentation. So thank you for your patient listening. If there are any questions now, we will take it.
Yeah, thank you very much, Dr. Paul. Trainees, you may type your questions, comments in the chat box. You may stop sharing the screen, Dr. Paul, now.
Yeah, okay.
So you can start with the Q&A first.
Just open the Q&A. So how to decide surgical margins, as there's so much discordance between biopsy and final HPE, whether to use frozen for margins. Okay, the question is about use of frozen. In Phyllodes tumor, frozen will be very difficult because, it's like a three-dimensional 360 expansion, and any part of this could be a concern. We don't recommend frozen for Phyllodes tumor margins. And I have not seen that in literature either. So at the moment, the protocol is no frozen. I think if you have a doubt that you have gone close to the capsule at any point, I would suggest you re-excise that margin and try to keep the specimen intact as far as possible and not to take tissue separately. I think that's, I would say, think of it as a ball of tissue and it's not well encapsulated. So you've got tumor cells coming right onto the margin. So any handling or injury to that capsule, the very fine capsule, will always dislodge tumor cells into the tissue area adjacent, and that's probably what causes so many recurrences. So if you accidentally get onto the capsular surface, what I usually do is to just retract and then retake the tissue wider so that whatever was dislodged in that area will come within your final margin. To actually send margins for evaluation has not been studied and has not been recommended. That's an interesting point, but I don't think frozen section has a use here. So whether you prefer to excise pectoralis major, okay, posterior margin. Now again, this is not a routine practice. If you find it's very important clinically and intraoperatively, your assessment of the tumor. So if you have a very large tumor, then what happens, even if it arises in the anterior or mid-breast, then it will expand so that the capsule is adjacent to the muscle. So if the tumor is large and is contacting the muscle on clinical or intraoperative assessment, then yes, it is definitely worthwhile taking a part of your pectoralis major or the serratus, as the case may be, deep, because that will be the only way you will be able to avoid contact with the deeper margin of the tumor. Because there the space is very loose, so once you get into it, and if the tumor is bulging into the retromammary space, then you will contact the tumor. So as you said, I think it's good to get under the muscle as you approach the posterior aspect so that you're not, I think the primary idea should be you should not visualize or contact the surface of the tumor, that you take that approach and then take the margins appropriately when you're dealing with a malignant or a recurrent tumor. So is it right to say that enucleation is better for smaller fibroadenoma? Yeah, I think, again, the age is a factor. If you're dealing with somebody less than, if you're dealing dealing with somebody less than 20 years old, then the likelihood of phyllodes is extremely rare. So I would advise you to treat it as a fibroadenoma. And you can just do a straightforward excision. Now, if you're dealing, say, with a 30, 35-year-old, even with a smaller tumor, then it's better to be safer and take a margin with any lobular lesion that appears to be a fibroadenoma and is benign fibroepithelial lesion on the core biopsy. So this, when you say enucleation, yes, it's actually, we call it excision biopsy, which is basically you stay outside the capsule, but you don't have to take a normal tissue margin. So it's a careful dissection where you can keep just some fibrous tissue between you and the capsule, but don't have to take normal breast around it. Right? When to address the axilla? Yes, thank you for bringing that up. Actually, I just touched upon it, but I didn't go into it. Now, that's one important point, that a malignant phyllodes spreads only by hematogenous spread, and the spread to axillary lymph node is extremely rare. It's documented as 1 to 2%. In our own experience of 150 cases, where sometimes it's a large tumor, you're practically doing a mastectomy, or the tumor is in the upper outer, we do take any enlarged nodes in the lower axilla. And the only case we have found metastasis was incidentally occurring breast cancer, IDC, which was occurring with the malignant phyllodes, and the metastasis was from the IDC and not from the phyllodes. So basically, we've not had a single case of axillary nodal metastasis. There have been very rare reports, but I think the strategy is the axilla is not a problem in this tumor. If you are near the axilla and there are enlarged nodes, sometimes, in our patients, we do find enlarged nodes. You can just sample without doing too much of a formal dissection, just to document that it is negative. And of course, this very rare case of co-occurring IDC is always there. So if you think it's clinically suspicious, then you take the low axilla along with it. But it does not have to be targeted dissection in any case of phyllodes tumor. In case of a large phyllodes, which surgery should be preferred? Excision with a wide margin and volume replacement, or mastectomy with immediate reconstruction, or mastectomy with delayed reconstruction. So again, it depends on the location, the site, the size, and you have to sort of be able to predict in your mind, after you do a wide excision, how much skin you're going to lose, and you can clinically move it back and forth and check how much stretch there is on the skin, how much excess skin the patient has. It varies a lot between patients. The general principle, what we found, as I said, there is a large tumor tissue expander effect on many of these, and we find that many we can actually get away with primary closure even with a wide excision of skin. But certain tumors, especially younger patients who have large tumors, the tissue is not so stretchable, so that expander effect doesn't occur. They are the ones, young patients, where it just sticks out. It's not hanging or thick, so you don't get the spreader effect. And there you will require a flap reconstruction, large tumors in younger patients. And there it's your choice whether you want to do volume with replacement with immediate reconstruction or delayed reconstruction. Generally, we don't advise the same protocol of reconstruction with a silicone implant. If you're going to give radiation, whether to put an expander and then do that usually is not done in this situation. It would be best to do an immediate reconstruction and then radiate is what I would recommend. I think that takes care of the questions in the Q&A box. Is there anything I've missed?
You may open the chat box now.
Okay. Okay, so here's the chat box. Okay, the first question is how you decide RT. So I suppose you mean when do you give radiation? Again, it is controversial. I think the broad principles are benign phyllodes does not need radiation. Borderline phyllodes, as I said, behaves like benign usually. So therefore, we don't give radiation in borderline upfront surgery. You can consider it when you have a recurrent borderline large difficult operation. And in malignant and recurrent malignance, generally we do advise radiation. That has been our protocol. And there, I think that is also what the NCCN recommends. But again, it is an individual decision. We don't have robust evidence to prove or disprove the role of RT. And as we know, generally sarcomas don't respond too well to radiation. That's why we're a little careful about recommending radiation in this malignant phyllodes as well. But except where the tumors are more aggressive and they may have a role. In our own experience, I mentioned we found there was better response, less recurrence after radiation, but we couldn't achieve a statistical significance. Role, yep, same question, post-mastectomy RT. Can mammography differentiate benign and malignant? No, unfortunately, mammography can't. There is no imaging to differentiate benign and malignant lesions. As we saw, even benign can reach sizes of 30 centimeters. So the size, although the average size of malignant is larger, benigns also can achieve quite large size. The appearance generally is similar. Obvious malignant lesions which appear infiltrative can be seen clinically or on imaging. There's potentially a role of MR to detect this, but otherwise it is clinical and or biopsy decision mainly. So PMRT again to role, especially in recurrence, yes. I think borderline recurrence to consider and malignant recurrence is strongly recommended. Yeah, I mean what I mentioned earlier. If mastectomy is done for borderline and a margin 2 centimeters, can RT be avoided? Yes, I think definitely. If you are confident at your surgery that you have cleared and your pathology supports your clearance in a borderline situation, RT can be avoided because, as I said, borderline you have to think behaves like benign. So you think borderline benign is basically two categories because of the confusion of pathology in terms of very subjective assessment criteria. So borderline category is basically a place where the pathologist, it's basically benign, but there are some features where they're not very happy in labeling where they put it borderline. Okay, it's not the other way around that the malignant comes to borderline. So if your pathologist is reliable, you can be confident that most of the borderlines will behave benign. So your approach in management also will be more towards benign than malignant. But of course, there are exceptions again. So this is the problem in managing this. So ultimately, individualization of the decision, knowing the factors that are operating in this situation, what is the reliability of the information you are getting. Ultimately, it's a clinical decision. That's the important point. Any difference in RT dosing? No, I think they use the standard chest wall radiation dosing that's used in breast cancer as well. Any size criteria you consider for RT or mitosis for borderline? Okay, so I understand your question is whether radiation decision will depend on size or mitotic rate in the pathology when dealing with the borderline tumor. Again, so the classification of borderline will be 5 to 10 mitosis per high power field. So if that is recorded accurately in the pathology report, the size is more a criteria that you decide whether your margin was adequate or not. Now, when you have a larger size, then sometimes the margin will fall. However, your excision is however well it is done. So, if you find that, say, you have margins are close, less than 1 millimeter or less than 2 millimeters in some areas, and or they say that there's no margin visible at certain points, then you're concerned you may have contacted the tumor capsule. And if it is a large tumor and your mitotic rates on the higher side, maybe 9, and there are some other features your pathologist is not happy with, again, so that's an individual call you have to take. Your patient is also wanting to, take all options to prevent recurrence. So this is the discussion you have to have with your patient and take a call whether radiation. And it's best to take this in the MDT situation, in a discussion with your radiotherapy colleagues. Okay, I think that covers the chat box. Yes. Any other questions have come up since?
You have covered all the questions. Thank you very much, Dr. Paul, for this presentation. Thank you very much, trainees and faculty members, for joining the session.
Yeah, thank you all. I can see about 100, so it's been a great morning. I wish you all the best in management of these interesting tumors, and perhaps you can also contribute your experience in literature. All the best.